Okay, so what I would like to talk about today is two very interesting and important topics. One is suicide, which, as I will just mention in a few words, in a few seconds, is quite a huge impact on our society still today. And the other thing I'm going to focus on is inflammation, neuroinflammation, how it is involved in the background of suicidal behavior, and how it could be exploited for better management of suicidal behavior, including the development of biomarkers and also new targets for understanding, but also for screening, preventing, and possibly treating suicidal behavior. So I'm sure we all know a lot about suicidal behavior, but because it is such an important phenomenon, not only in mental health care, but also in public health and also on a societal level, it cannot be stressed enough. So let's just quickly summarize the impact of suicide in our current society, in our current world of mental health care. What we have right now is that every year there is more than 800,000 people who are claimed by suicide every year, which means that there is a suicidal death taking place every 40 seconds. And what's even more hurting is that in the young age group, which is the late adolescent years and also the young adult years, suicide is the leading cause of mortality. Now, if we consider the impact of suicide, it is even going to climb higher. These figures are even going to climb higher in the next 8 to 10 years, which means that by 2030, there will be even more suicidal deaths every year, and suicide will account for 1.4% of all the deaths worldwide. And if we are not just we are considering not only suicidal deaths, but all the suffering caused by suicide, then we have to be aware that these numbers, the numbers associated with suicide and the numbers associated with suffering related to suicide are even higher than we think right now. First of all, because suicide, completed suicide, numbers of completed suicide are highly underreported due to societal taboos and criminalization in several societies. So even the number of completed suicide is likely to be higher, but it is not only completed suicide, which means suffering for our patients, which means suffering also those around our patients, including family members, but also suicidal attempt. And if we consider that for every completed suicide, there are at least 20 suicide attempts, then we understand that the toll suicidal behavior takes on our societies is huge. So we understand that suicide has a profound impact on mental health, on mental well-being, and is still a critical issue in mental health care. Now, suicide has a huge impact, we know this, but the problem is that the management of suicide is even associated with a large number of unmet needs in the management of suicidal behavior. First of all, the prediction and also the prevention of suicidal behavior is still challenging, because although we can identify several risk factors which are clinical in nature, psychosocial in nature, and social demographic in nature, and they can be considered as prognostic indicators, but the problem is that their predictive value and their specificity is in fact quite low. Currently, what we have is the strongest predictor of suicide, which is a previous suicide attempt, but the problem is that suicide attempt is also associated with significant suffering, as I have just mentioned. So we would like to prevent also the previous suicide attempt and not use them as predictors of subsequent suicidal behavior. And also previous attempts and the other currently understood suicide risk factors and prognostic indicators are also non-modifiable and have a low predictive value. For example, if you just think of low predictive value and non-modifiability, the majority of suicidal patients, 40% of them, visit their GP or the emergency room at least once in the preceding 12 months prior to their death, and 28%, which means more than 1/4 of them, have at least 3 visits. We see these patients in the emergency care, we see these patients in the family medicine practice, and we are still unable to screen, to understand and to catch that they are going to commit suicide. So we have the chance, but this prognostic indicator, this risk factor, which is present in the emergency room or in the GP practice, when these patients visit them, are not good enough so we can screen for the approaching suicide in these patients. So we fail to identify high-risk individuals, which reflects the high insufficiency of our current suicide risk assessment schemes. So what do we need to meet these unmet needs, what do we need to improve the prediction and thus the prevention of suicidal behavior? Besides these psychosocial and clinical and social demographic risk factors and prognostic indicators, we would need objective markers and biomarkers, which are more specific, which have a better predictive value, and which also reflect modifiable processes, and use these objective biomarkers to improve the prediction, the risk screening, and the risk assessment of suicidal behavior. And based on these objective markers and biomarkers, we also need to develop efficient methods for the prevention and intervention of suicidal behavior. If we manage to identify, in order to be able to manage to identify these objective markers and biomarkers, we would need a much better insight into the neurobiological processes in the background of suicidal behavior. And we need to go beyond our current understanding of neurobiology, because we see that these are not useful enough. So what we would need, we would need novel targets, novel systems involved in suicidal behavior, and novel approaches to understanding them. And based on this recruitment of novel neurobiological processes in our understanding in suicidal behavior, we would need better behavioral and biological indicators, based on which biological and behavior indicators we can actually develop better diagnostic methods and make it possible to identify suicidal risk factors in a more reliable and more timely way. Now, the importance of suicide and the importance of understanding suicide from this neurobiological aspect and predicting suicide from this neurobiological aspect is also reflected in a recent change in the DSM system, because now DSM considers suicidal behavior not just a side effect, not just an outcome, or not just a symptom of certain psychiatric behavior, but considers this as an independent phenomenon. So now we have suicide behavior disorder, SBD, in DSM-5, which is a disorder for further consideration and potential acceptance into the diagnostic system. So this is a big step for understanding the transdiagnostic way, the transdiagnostic nature of suicidal behavior. Now, there are many factors which actually hinder or make it difficult to understand the neurobiology of suicide, and one is the heterogeneous nature or multifaceted nature of suicidal behavior. Now, we all know that suicidal behaviors can take place, can happen, or can be manifested in many forms, which stand for suicidal ideation, just thinking of suicide, the suicidal gestures, which are usually following some kind of a narcissistic injury. We have different types of suicidal attempts, including those which are not lethal, just impulsive, and those which can be considered actually incomplete or aborted completed suicide. And we have completed suicides too. So we usually consider suicidal behaviors along the suicidal spectrums and categorize them based on the intent to die, the lethality of the method involved, and the injury of the method involved, or the injury of the method has caused. Now, the problem is that there are other factors in the background of suicidal behavior which call for another type of categorization, and also the fact that suicidal behaviors are heterogeneous not only on the level of manifestation, but this heterogeneousness on the level of manifestation also points to a heterogeneousness in the level of neurobiology involved, also makes it necessary to categorize suicide or to place suicidal behaviors along a different type of spectrum. And this different type of spectrum is one that is stemming from the internal neurobiological causes and the external or environmental causes. Why is this important? Because, as I have just mentioned, these different types of suicidal behaviors, from ideation, through attempts, through completed suicide, also have very important differences in their etiological factors, and the differences between the etiological factors also call from the differences on the level of treatment. If we have suicide where internal or biological factors are more important, then we will definitely need biological interventions. If the external or environmental components of the etiology are more prominent, then may not even need biological interventions, but psychological interventions are going to be more dominant or more prominent if we want to prevent this type of suicidal behaviors from reoccurring. So what is the difference is that in case of a suicidal behavior that is highly endogenous, there may not be environmental triggering causes, that may not be so personality factors which make it harder to react well to these environmental reactive causes involved, but maybe solely neurobiological processes in the background of suicidal behavior which drive the motivation to self-destruct. So what are these more endogenous types of suicidal behavior where there is a more pronounced involvement of biological processes? Of course, both ends of the spectrum are present in case of all suicidal behavior. It is only the question of which is more dominant. So those instances of suicidal behavior where these internal and neurobiological factors are more dominant includes those suicidal behaviors which accompany somatic illnesses related to inflammation or immunological disorders or processes. For example, those states when there is a high infection state, autoimmune disorder, or those patients who are receiving biological treatments. In case of suicidal behavior or suicidal intent occurring in these types of patients, it is usually associated not so much with the external factors causing some kind of a crisis, but the internal biological processes which are disturbed. Also, suicidal behaviors occurring in case of major psychiatric disorders, such as schizophrenia, such as major depressive disorders, are in many cases more driven by biology, for example, monoamine disruption or HPA axis dysregulation than actual external or environmental events happening. On the other hand, we have certain cases when the problem is the environmental trigger and the capability of reacting well and reacting adaptively to this environmental trigger, such in case of suicide associated with personality disorder or suicide associated with acute crisis, losses and narcissistic injuries. And in these cases, it is not so much the biological intervention which is needed, but much more a psychotherapeutic intervention, which is going to restructure how these patients react to these environmental triggers and stressors, and to make them be able to cope better with them. So the problem is that we need to understand that suicidal are heterogeneous, not only their manifestations, but also in their etiological background. And we need to understand which suicides are associated with more of an internal and biological disturbance. And we also need to understand the contribution of different parts of our biology and neurobiology to this internal biological disturbance. And one novel approach to understanding suicidal behavior and understanding this markedly biologically determined suicidal behavior is understanding how infections, immunological processes, and inflammation plays a prominent role in suicidal behavior. So let's speak a bit about neuroinflammation. So let's start from jumping from the mind to the body and from the body to the mind in understanding suicidal behavior. Now, for a long time, neuroinflammation or inflammation rather was considered a primary pathophysiological mechanism in chronic somatic illnesses, but we thought that it is not associated with any kind of mental or psychological or psychiatric processes. And we actually thought that the brain is isolated from the peripheral immune system. And then a recent paradigm shift happened, and now primarily based on observations that there are inflammatory alterations in several psychiatric disorders, also in the major neuropsychiatric disorders, including affective disorders such as major depressive disorder or even schizophrenia. So now we understand that the central nervous system is not isolated from the peripheral nervous system, but in fact there is a multiple immune surveillance in the central nervous system, which is composed from also from peripheral factors and also from local factors. So now we know that cytokines can actually cross the blood-brain barrier and convey signals to the central nervous systems, but these cytokines which have a profound impact on our nervous system are not only the ones which are produced in the periphery, but they are also locally secreted by microglia, by astrocytes, and by endothelial cells, and they have a very important function both in neurodevelopment and also in the maintenance of central nervous function. So we are of course not saying that mental illnesses are immunological disorders, but we are saying that there are subgroups of symptoms and across multiple psychiatric disorders in which neuroinflammatory processes and cytokines are involved. And since the understanding that the brain is not isolated from this, from the immunological processes, and since the understanding that there is a role for neuroinflammation of psychiatric disorders and also suicide, we have a large number of studies. Of course, we had the initial observations if we consider suicide and neuroinflammations. The initial observations were stemming from, first of all, that there is an immunological response leading to elevated risk of self-violence violence and suicide in patients infected with Toxoplasma gondii, which is a brain tropic parasite, and also from the fact that somatic conditions which are characterized by prolonged immune overactivation, including both autoimmune disorders and also allergies, are also associated with the high suicide rate. Then, based on these initial observations, we had a large number of clinical studies which show that there is alterations in different types of cytokines, mostly interleukin-6, in all kinds of suicide behavior committers, including recent suicide attempters, including suicide attempters, and those who committed suicide. And we also have several clinical studies which show the different aspects, different sides of inflammation can be demonstrated in suicidal patients. And we also have very high quality studies and analyses which show that there is a strong and robust association between neuroinflammation and suicidal behavior. For example, there are prospective studies which show that those patients with increased inflammation were up to 4 times more likely to commit suicide compared to those with less inflammation in depressive patients. And we also have a large sample meta-analysis which also points to the involvement of certain cytokines, mostly the previously mentioned interleukin-6 and also interleukin-1 beta, and the association between these and suicidal proneness. And these meta-analysis also indicates that the elevation of the level of these cytokines is able to distinguish within depressive patients between those who are more likely or less likely to commit suicide. So what we know now based on all these studies is that there is an inflammatory signature in suicidal victims, which is irrespective of the primary diagnosis and their underlying conditions. So this inflammatory signature should be able to help us distinguish between suicidal and non-suicidal patients also within a psychiatric disorder groups. So let's place the association between inflammation and neuroinflammation and suicide into a bit of an evolutionary context to help us understand that how is it possible that inflammation, which usually, as we understand it, takes place in our body, and inflammation, which is actually designed by creation or by evolution to make us better, to be able to better survive in case of an injury or in case of an infection. So why are these processes, which are actually designed to help survival, turning ourselves against our own being and making ourselves terminate our lives? Now, what we need to understand that until quite recently, until the last century or until the few decades, the major cause of death were infections, infections in themselves or infections due to injuries. So if we are speaking of a larger time scale, that we see that until recently 50 patients of adults or 50 patients of people actually did not reach adulthood. They died before adulthood due to infections. And because of these infections and those processes which are designed at coping with infections, this is inflammatory and immunological processes, and the genes which are coding these processes have been involved in evolution in very markedly. So actually this infectional death has been a strong selective pressure for those alleles, for those genetic alleles which enhance host defense. Now there is, as a result of this strong selective pressure, microbial infections have been the primary drivers of human evolutions. The patterns of inflammatory activations, which are associated with depression today, actually promoted survival in an evolutionary scale in highly pathogenic environments. And the problem is that it is the fact that we are not exposed to highly pathogenic environments is the achievement or the result of only the last century. So this means that those processes which are involved in inflammatory activation and promote survival in highly pathogenic environments in these modern conditions, in these better sanitary conditions, do not help us but increase mortality. This has been proven in several lines of research. For example, in large-scale genome-wide analytical studies, which have shown that the best replicated risk alleles for depression are actually those alleles which are involved in pro-inflammatory effects, or which are involved or implicated in such behaviors which are directed at reducing the risk of inflammation, directed at reducing the exposure to pathogenic effects. So those risk factors, or those environmental risk factors, which are also risk factor for the development of depression and also suicidal behavior, used to be related to infections, but they are stressors, whether related to infections or whether related to modern psychosocial effects. So now all those stressors which have been earlier related to a risk of infections are now in fact those stressors which are still present in our societies, such as early traumas, psychosocial stressors, or stressors related to our lifestyles, for example, eating a high ratio of processed food or being obese. And these are uniformly pro-inflammatory. So stressors are stressors, whether they are related to risk of wounding or risk of infections, or they are related to lifestyle of psychosocial stress, they are uniformly going to activate our pro-inflammatory mechanisms, because these stressors make us expect that there is going to be some kind of wounding or some kind of infection taking place. So these stressors leading to pro-inflammatory mechanisms will mean that there are going to be an increase of levels of pro-inflammatory cytokines, and the exposures to these pro-inflammatory cytokines, whether on the acute level or on the chronic level, is going to lead to a change in behavior. And this change in behavior on the evolutionary level is going to be targeted at reducing the risk of infection or reducing the risk of death from infections. So actually these pro-inflammatory cytokines are going to fine-tune or going to change our behavior so that we are decreasing our energy expenditure, which means that we are going to be more targeted towards energy conservation, decreased motivation, decreased exploratory activity, decreased mood for doing anything, which is behavioral syndrome referred to as sickness behavior, but this is also a behavioral syndrome which is very reminding of what we call depression in our current societies. So just to sum up, so why would a stimulus which is in our present world devoid of any pathogens induce an inflammatory response, and why should this inflammatory response promote the development of depression or suicide? So as I have just mentioned, in ancestral times, stress threatening survival were more related to the physical environment, and pathogens were more related to threats related to injury, and more related to stress of infections related to injuries. So this was the major stress, and because of this, the stress-relevant neuropsychiatry is strongly coupled based on evolutionary steps with immunity forming an integrated system. Now, the problem is that in modern times, the major stressors are not the environmental stressors of pathogens, of injury and wounding, but are psychosocial stressors. But as I have mentioned, stress is stress. So stressor, even if is psychosocial in nature, is going to activate the same key inflammatory pathways and is going to activate the same inflammatory peripheral blood mononuclear cells, which is going to trigger an immunological response, which is manifested in the increase of circulating pro-inflammatory cytokines. The problem is that this immune response in response to stress has been in ancestral times directed against a pathogen, but in our modern times it is not directed against a pathogen, but against the subject's own mental health and mental well-being, and against the subject's self-esteem in case of social stressors. So now we understand that why neuroinflammation can trigger psychiatric illnesses and why neuroinflammation can actually trigger suicide. But now let's step back to the future and understand, based on this current knowledge, the current challenges we face in understanding and managing suicide on the clinical level. I have mentioned that they have several risk factors of suicidal behavior, which are familiar in nature, developmental, environmental, psychosocial, psychological, or medical. But these risk factors of suicide that we have currently are unable to specifically predict if suicidal behavior is going to actually take place in case of a patient or in case of a person. Now, what is interesting that there are such molecular factors also in the background of risk factors related to these factors, which are involved in genetics, epigenetics, and also in the gene expression in the brain and in the endocrine and immune system. And these molecular factors, which can be a trigger, which can be activated as a result of these risk factors, will be associated with alterations or increase in the production of cytokines and in cytokine signaling. So it is also interesting that this cytokine system may be also involved in these multiple predisposing or precipitating risk factors of suicidal behavior, which we have known before. And although they had a low predictive value and a low specificity on their own, but if we understand the neurobiological background and also test for the neurobiological and neuroinflammatory processes associated with these factors in case of our patients, then we may be able to identify better biomarkers associated with our traditional risk factors, which may be able to help us finding tools for screening and also preventing suicidal behaviors. So let's get back to the point. We now understand that neuroinflammation is involved in psychiatric processes as involved in suicidal behavior. And we also know that this may help us identifying important biomarkers. Now, first of all, in order to be able to use neuroinflammation and those molecules which drive neuroinflammation, which are cytokines, to develop biomarkers based on them or to develop intervention targets based on them, we need to understand who they are. So let's take a quick look at these cytokines who will be involved in inflammation and neuroinflammation. Now, if we consider their nature, then cytokines are polypeptides, a quite heterogeneous group of polypeptides, which can be released in the periphery by immune-competent cells, such as lymphocytes and macrophages, which cytokines, even if released on the periphery, as I have mentioned before, are able to cross the blood-brain barrier. But they are not only produced on the periphery and then transported to the brain, but they are also produced in the brain by microglia, by astrocytes, and by endothelial cells. And they are increasingly recognized as messenger molecules towards the central nervous system or within the central nervous system. Now, traditionally, cytokines had the role of host defense and tissue repair processes, but they also have a very important role in brain, both on neurodevelopment, on brain development, but also in maintaining the healthy brain function by supporting neuronal integrity, neurogenesis, and also sympathetic remodeling. And they also impact those neurocircuitries and those neurotransmitter functions, which are involved in profound behavioral alterations in case of a change and the expression of different types of cytokines. So besides being implicated in neurodevelopmental disorders due to their role in brain development, they are also implicated in the neurobiology of stress-related conditions such as mood disorders and suicide. And the most relevant pro-inflammatory cytokines involved in psychiatric disorder and also suicidal behavior appear to be interleukin-6, interleukin-1 beta, and TNF-alpha, and they are quite remarkable when we are considering their role in the central nervous system because they have a pleiotropy to bind to a large number of different cell target types in the brain. So now we know who cytokines are, and now let's quickly summarize what they do in suicidal behavior, because cytokines in the brain can contribute to suicide-related changes via several mechanisms. First of all, they have receptors in specific brain regions, so they can directly influence neuronal function, and they can induce the specific effects on behavior and emotion. And these receptors are especially markedly expressed in several suicide-relevant brain regions, which include the prefrontal cortex, the hippocampus, or the amygdala. And we also have to mention that, as I have said, that they can cross the blood-brain barrier, those cytokines which are not produced in the brain, but also they can cross the blood-brain barrier with active transport, but they are much more easily crossing the blood-brain barrier if it is compromised. And actually, the blood-brain barrier has been reported in several studies to be leaky in suicidal behaviors. Now we see that cytokines can have a profound effect on neuronal function, and they can exert their effects via various biomechanisms and various targets. And those targets which we know already that are involved in suicidal behavior, for example, they can activate the kynurenine pathway of the tryptophan catabolism. They also are able to dysregulate the HPA-axis homeostasis. They have an effect interfering with monoamine metabolisms, and they also contribute to long-term epigenetic changes. And these, especially the kynurenine pathway, HPA homeostasis, and monoamine functions, have been long known to be involved in the neurobiology of suicidal behavior. So we know now that cytokines are able to influence suicidal behavior, but what are those suicide-related phenotypes, which can be both state-like and trait-like, which are strongly associated with inflammation? So how do cytokine changes lead to those phenotypes which are going to raise the risk of suicidal behavior? Now, we already talked about that the proinflammatory cytokines are related to the induction of what we call sickness behavior. And as I have mentioned, this sickness behavior is related to such behavioral changes which made us more likely to be able to successfully cope with injuries, wounding, or infections on an evolutionary level. And they were changing our behavior in such a way that we reduce our energy expenditure. So they were inducing a state of depression and a state of lethargy. It also made us withdraw socially to decrease risk of infecting others. So in fact, sickness behavior associated with pro-inflammatory serotonin activation was directed at actually increasing our survival in case of wounding or in case of infection. But as we see, this sickness behavior is actually a mirror effect of what we call depression on our current societies. So this is a state which resembles depression, which is associated with the activation of pro-inflammatory cytokines. Now, also chronic exposure to inflammatory cytokines, especially during neurodevelopment, is associated with the development of such vulnerability behavioral traits, which are associated with both suicidal behavior and inflammatory markers of cytokines. And if we look at these with these traits which are associated with pro-inflammatory cytokines, then we see that they actually map all those psychological traits which are known to be associated with suicidal behavior, especially if they appear in constellation. So cytokines, pro-inflammatory cytokines, are related to the development of hostile, angry, and aggressive traits, especially in case of interleukin-6 and C-reactive protein. They are also associated with the development of hopelessness and pessimism, and also neuroticism and harm avoidance. Now, cytokines, besides the trait of these factors, and also besides the sickness behavior, which resemble depression, are also associated with the distinct pattern of cognitive changes, which have also been described in suicidal behavior, characteristic changes in the verbal memory processes, in cognitive speed, and in certain executive functions. And also, we know that circulating pro-inflammatory cytokines may affect mood states via the alteration of the functional alteration of limbic circuits. So now we also see that whether they have an impact on neurodevelopment or whether they have a direct impact on our current states, cytokines are involved in the emergence of suicidal behavior or the emergence of suicidal risk on multiple levels, both involving traits, long-term change, and acute straits. So now we know a lot about neuroinflammation, we know a lot about cytokines, we know who they are, we know what they do. Okay, we still have suicidal patients. How can we exploit our current knowledge about neuroinflammation and cytokines for the management of suicidal behavior, for the management of suicidal patients? So what is our current understanding of neurobiology and neuroinflammation in the background of suicidal behavior good for? Now, when we are speaking of how we can exploit neurobiological processes in preventing, predicting, or managing something, we always have two major targets. One is screening and prediction, and the other one will be intervention. So now let's start with screening and prediction. How can we use our current knowledge of neuroinflammation and on cytokines to screen and predict suicidal behavior? We strongly believe that suicide is actually predictable and preventable, although maybe not with the current strategy. Our current strategy on predicting and preventing suicide actually involves the collection of data, clinical and social demographic data from medical reports. It is also built on major life events collected, which is reported by the self or by collateral information, family and friends. We also use self-reported scales on suicide thoughts and risk, and self-reported measures of related psychopathological symptoms or states, such as depression and anxiety, or self-reported scales on related personality markers, such as neuroticism or aggression, and we also use clinical interviews. And the problem with our current strategy is that it's very subjective. We rely on self-report, on what the patient wants to disclose, and we all know that several suicidal patients understand that if they pronounce that they are suicidal, then they are going to be locked up in psychiatries, so they have a high motivation of not actually reporting their intent of committing suicide. So one problem is that it's very subjective. The other problem is it is very laborious. It takes several hours from the clinical personnel to evaluate suicide based on our current strategy. But the biggest problem is that in spite of this hugely laborious and time-consuming process, that it's also often of very low predictive value. So instead of this, what we need objective indicators which have a high predictive value, which can be more easily screened and more time effectively screened, which also reflect modifiable processes, such as, for example, the use of inflammation-related biomarkers. So actually, if we use this multi-stage system of suicide behavior, suicide prevention, prediction, and treatment, then objective biomarkers, for example, neuroinflammation-related biomarkers, should become part of this multi-stage system for evaluating risk of suicide. Now, how can we use inflammatory biomarkers to predict suicide? Now, one thing we have to understand that, of course, it is not always the newest process which is only reliable or responsible for the appearance of suicidal behavior. So although we now understand the role of the dysregulation of immune system in the background of suicidal behavior, this is not going to be the only system which needs to be evaluated, not going to be the only system where biomarkers need to be incorporated in screening of suicidal behavior, but will only be one part of this huge protocol of possible biomarkers which can predict suicidal behavior. But if we are only speaking of neuroinflammation and dysregulation of the immune system in the background of suicidal behavior, as we do today, then we have to consider that cytokines have been proposed as suicidal biomarkers more than 5 years ago, so several years ago already, because we have a huge number and an increasing number of studies which actually show us that suicidal ideation can be significantly associated with individual cytokine alterations and also with inflammatory indexes, for example, comprising several cytokines which show an alteration in suicidal behavior. So we can develop not only individual cytokines as biomarkers, but also different indexes based on these cytokine alterations of suicidal behavior. Also, there have been attempts to identify hemogram parameters like ratio between different types of immunological cells, different types of white blood cells, which have been shown to be able to predict, for example, adolescent suicide in one very recent study. And we also have some kind of signs that we are going to be able to develop imaging biomarkers for approaching suicidal behavior. So we have several possible targets to develop neuroinflammation related biomarkers of suicide, but of course these are going to be only one step in our hopefully soon developing multi-stage process of using biomarkers in predicting suicidal behavior. And as I have mentioned, screening and prediction is only one target in case of management of suicidal behavior, and the other target is the prevention, the intervention, or the treatment of suicidal behavior. And actually, we hope that we are going to be able to use our neuroinflammatory understanding, our current advances in understanding neuroinflammation in suicide for therapeutic reasons as well. Especially that currently we have a growing frustration over the lack of new psychiatric medications in general, and also specifically for suicide and for those psychiatric illnesses which are mostly associated with suicidal behavior. Actually, we currently have some kind of pharmacological interventions of suicidal behavior, but they are not really effective. First of all, they utilize medications which focus on the underlying psychiatric illness and not suicide itself, but we have mentioned in the beginning of this lecture that suicide is an independent and transdiagnostic phenomenon, so we should not only focus on the specific psychiatric illness associated with suicide in case of a given patient. Our current pharmacological interventions targets almost exclusively monoamines, and we know that they are not sufficiently effective. So for all these reasons, we need new paradigms and new targets, and neuroinflammation hopefully promises a few exploitable targets. Especially because inflammation and neuroinflammation target such neurocircuitry in the brains, which regulate processes we know are involved in suicidal behavior, for example, anxiety, arousal, alarm, also motivation. So this can be exploited for intervening in the approaching suicidal behaviors. And actually, we have some kind of a promises if we look to the future, because we have some novel treatments, for example, such as esketamine, which point to new molecular targets. In this case, we move beyond the monoamine system and we move towards the glutamate system. And we know that ketamine or esketamine is not only effective at robustly and fastly decreasing depressive symptoms, but also by fastly decreasing the risk of suicidal behavior. So based on our understanding on the action mechanism of ketamine, we may exploit the glutamate system for anti-suicidal therapy. Then we also have as a novel target the GSK3, glycogen synthase kinase, which this enzyme is known to be associated with increasing pro-inflammatory cytokine levels and promoting aggression in depression, which is a prominent mechanisms in the background of suicidality. And one already known fact which may show us that inhibition of this molecule may be an effective way of intervening in approaching suicidal behavior is that lithium, which has a well-known anti-inflammatory effect, may exert this anti-suicidal effect, may exert this anti-suicidal effect due to inhibiting this GSK3 enzyme. And we also have, if you look towards the future, other anti-inflammatory strategies which may help us reduce the risk of suicidal behaviors. For example, boosting regulatory T-cell response also in the central nervous system, which may regulate increased pro-inflammatory cytokine levels. But until we develop these new medications, these new novel targets for medications, as I have just mentioned before, we can have another way of therapeutically intervening in suicide risk and suicidal behavior, and do this by repurposing already existing medications and give new avenues for the use of these already existing medications. And we actually have a large number of different molecules and different medications which are used today for the treatment of inflammation, for the treatment of for the treatment of immunological disorders, or for example for the treatment of cancers, which could be repurposed and used in the treatment of suicidal behavior. For example, studies indicate that those non-steroidal inflammatory drugs, which are actually anti-inflammatory, are associated in a large population level with decreased suicidal ideation. We also know that COX-2 inhibitors, TNF-alpha antibodies, interleukin-6 antibodies have been shown in limited studies to be associated with decreased symptoms of depression. And we also have other molecules, for example, minocycline, which is a tetracycline antibiotics, and pentoxifylline, which is a vasodilator and phosphodiesterase inhibitor, which are associated with decreased inflammatory parameters, and which have been tried in some smaller studies in case of depression and have been shown to be associated with the decrease of depressive symptoms. Now, we are mentioning studies in depression because we all know that it is very difficult to conduct clinical studies in suicidal patients due to ethical reasons, and generally suicidal patients are also excluded from these smaller depressive studies. However, given the known association between depression and suicidal behavior, understanding how these medications which reduce inflammation can actually reduce the severity of depressive symptoms will bring us one step closer to understanding and to discovering how they are associated with decreasing also risk of suicidal behaviors. So we know that we will develop new medications. We also be able to repurpose medications when we can test them also in case of suicidal behavior. But until we can do this, let's see what we already have, because we already have intervention mechanisms, intervention possibilities, which are actually capable of reducing inflammation, because we have psychotherapies, which in several studies have been shown to be able to reduce different inflammatory markers. And what is interesting about psychotherapies is that this seems to be independent of the psychotherapeutic modality or the psychotherapeutic method used, because one very recent meta-analysis showed that when testing 8 different types of psychosocial interventions in almost 60 randomized controlled trials and more than 4,000 patients, it has been shown that psychotherapies in general are associated with decreased level of pro-inflammatory cytokines. Why is this good for? Because psychotherapies do not have the regular side effects of pharmacological agents, and also these anti-inflammatory pharmacological agents, which are traditionally used for other other very severe somatic illnesses. And because and also it is very good for us, because this way actually we would have suitable candidates, suitable intervention candidates to intervene in those cases when there is a high risk of suicidal behavior. And also we can use cytokines or monitoring the levels of cytokines to test for the efficacy of psychotherapies, which is especially important if we are using them in case of those patients who are at a high risk of suicidal behavior. So while we are developing new targets for intervention in suicidal behavior based on neuroinflammatory processes, we can already exploit the effect of psychotherapies of reducing risk of suicide via also reducing inflammation processes. And we also have several lifestyle factors which also influence inflammation, and several lifestyle factors which thus may, on a large population level, contribute to the increased risk of suicide in certain populations, and those lifestyle factors which can be influenced. For example, vitamin D deficiency has also been associated with pro-inflammatory states. We also know that several molecules in foods, for example, omega-6 fatty acids, especially the high ratio of omega-3 to omega-6 fatty acids, have been associated with inflammatory processes. So the setting the high ratio of these two molecules in our food may also help us alleviate inflammation, and on the long term may help us alleviate the risk of certain neuropsychiatric disorders and also suicidal behavior. We also have other lifestyle factors associated with a higher inflammatory level, for example, sleep loss or exercise. So we have actually several targets on the lifestyle level which could be exploited for decreasing the risk of suicidal behavior. So, to sum up what we have been talking about today, we have suicidal behavior, which has a huge impact on our societies, not only on mental health care, not only on the subjective well-being of our patients, but also public health and also on a societal level. But we are running into current difficulties in understanding and managing suicidal behavior, in screening, predicting, and preventing suicidal behavior. But it does not mean that understanding neuroinflammation at this current moment can help us all our problems, because we already have several difficulties in making use of our current understanding on the involvement of neuroinflammation in suicidal behavior. For example, in suicidal patients, produced pro-inflammatory activity. So this means that suicidal patients, those patients at suicide risk, might benefit or may benefit from anti-inflammatory therapies, but we have a difficulty in testing the effects of these anti-inflammatory agents, because suicidal patients, as I have just mentioned, are often excluded, or most often excluded, from trials of these medications. Then there is another problem, that although we know that there is a produced inflammation, a produced pro-inflammatory profile in suicidal patients, but this pro-inflammatory state may not equally characterize all of our suicidal patients. And considering the side effects of anti-inflammatory therapies, we have to understand that we may not be able to target all suicidal patients or all possibly suicidal patients with anti-inflammatory drugs. So we have to identify those subgroups of suicidal patients when these inflammatory processes are more pronounced or more important. Also, as I have mentioned, these anti-inflammatory medications, whether they are non-steroids or COX-2 inhibitors, or whether they are directly targeting some cytokines, may harm those patients when there is no actually increased inflammations. So this makes it even more important to identify those patients, of those suicidal patients, where inflammatory is more marked. And this is very important to understand, because inflammatory cytokines have a profound role in our bodies, in our somatic level, and they also have a profound role in synaptic plasticity, neurogenesis, and also long-term potentiation, so several cellular processes. So it is very important that we cannot go against these processes in those patients where neuroinflammation is not even marked. Then we also have these currently usable and currently exploitable anti-inflammatory anti-inflammatory drugs, for example, minocycline, which is an antibiotic, for example, non-steroidal anti-inflammatory agents, but they have several off-target effects. So once again, we should we should implement these medications only in those patients who actually have increased inflammation. So what we do need to overcome all these difficulties, we do need to understand and we need to identify those targets which can be specifically targeted, which can be specifically influencing those inflammatory cytokines or their signaling pathways, which is associated with increased risk of suicidal behavior. And we need to employ these drugs in such a way that we can use them only in those patients where actually inflammation is more marked or more expressed. So what we need to do, we have a to-do list, and we also have several possibilities where this to-do list can be actually put to use, where this to-do list can be exploited. So what we need to do, first of all, we need to characterize suicidal behaviors, and we need to characterize those intermediate neuroinflammatory pathways which are implicated in suicidal behavior. So we have to understand very specifically how suicide is related to inflammation, and not only on the level of individual cytokines, but also on the level of pathways. We need to understand how our current therapies, including psychotherapies, or how our current lifestyle factors impact suicide via neuroinflammation, and how we could maximize the effect of psychotherapies and lifestyle changes in preventing suicidal behaviors. Based on our understanding of neuroinflammation, we need to identify better biomarkers, and we need not only to identify better biomarkers, but we also need to identify in those patient groups where these biomarkers are especially important. So we need to be able to identify those subgroups of depressed or suicidal behaviors who are at an increased vulnerability for inflammation, that is, who would benefit from anti-inflammatory therapies to decrease the risk of suicidal behaviors. And then we need, besides developing biomarkers, also develop neuropharmacological strategies or novel neuropharmacological targets within the immune system to be able to target this increase of suicide. And all these steps will make us able to measure, first of all, the relative status of immune response posing a risk. So we would be able to identify those patients who are actually at the risk of suicidal behavior due to the increased pro-inflammatory immune response. We would be able to detect who are at risk, and we will be able to target those patients who are at risk with preventive measures, which focus on neuroinflammation, hopefully without the side effects of anti-inflammatory molecules. And hopefully we would also be able to treat neuropsychiatric disorders such as suicidal behavior, also from the perspective of understanding neuroinflammation and developing new targets and new molecules targeting neuroinflammation. So I hope I have managed to increase everybody's interest in understanding novel biological processes in the background of neuropsychiatric disorders, such as suicidal behavior. And I also hope that I have mentioned to broaden our perspective on the neurobiological process of those mechanisms which are involved in the background of suicidal behavior. So I would only like now to thank you for your attention. Thank you.